In the next 3 videos, I will be describing the clinical characteristics of COVID-19. In this first video, I'll be describing the symptoms of COVID-19. In the second video, the laboratory and imaging studies used for diagnosis, and in the final video, I'll be describing how the disease progresses over time, or clinical course, and prognostic factors, or the conditions associated with a poor outcome. Let me begin with a case that I helped to manage. Some of the details have been changed to maintain confidentiality. This woman did not work at UF Health, but at another medical facility in Florida. This 50-year-old woman was a respiratory therapist. 6 days before her admission to the hospital, she had to change several tracheostomy tubes and clean a tracheostomy site. Subsequently, she learned that 3 of these cases proved to be positive for SARS-CoV-2. She knew that for these manipulations, she should be wearing an N95 mask. However, upon requesting one, the hospital administration reported their supply was depleted, and she was given a disposable surgical mask. 3 days later, she was turned away from her diabetes clinic during screening because she was found to have a fever. 2 days before her admission to the hospital, she began experiencing fatigue, fever, chills, and a dry cough. 1 day before admission, she was walking in the kitchen and noticed marked shortness of breath. And over the next 24 hours, her shortness of breath became progressively worse. Being a respiratory therapist, she checked her oxygen saturation. It was 83%, far below the normal of 94 to 100%. She was rushed to the emergency room. On admission, her temperature was noted to be 102.6 degrees Fahrenheit, and oxygen saturation was 88% on room air. Her chest x-ray showed pneumonia, and her SARS-CoV-2 RT-PCR from the nasopharynx was positive. She was placed on 4 liters of nasal oxygen, and her O2 saturation increased to 93%. On the second day, her respiratory rate suddenly increased to 38, and O2 saturation was 88% on 100% oxygen rebreather mask. She required intubation and ventilator support. Despite administering 70% oxygen, her arterial blood oxygen levels were markedly reduced, and she was placed on her stomach or placed in a prone position to improve her oxygenation. She next developed shock, and her kidneys stopped producing urine. Over the next 12 days, she remained on a respirator, and on hospital day 6, she received convalescent plasma. 48 hours later, her blood pressure returned to normal, her renal function normalized, and her oxygenation improved. And on the 17th day of hospitalization, she was extubated and is now receiving physical therapy. This case illustrates the potentially devastating consequences of this infection. What are the usual clinical manifestations of this disease? This graph summarizes a study of 1,099 cases of COVID-19 from China. There are 3 bars for each complaint. All the cases, medium gray, non-severe cases, light gray, and severe cases, dark gray bar. As you can see, nearly everyone has a fever, defined as a temperature of 38 degrees or 100.4 degrees Fahrenheit. On arrival to the hospital, 1/3 of patients may not have fever. However, most will have a history of feeling feverish, and fever eventually is documented in 95% of cases. The second prominent symptom is a dry cough, found in over 2/3 of cases. Patients early on do not bring up sputum, but in about 1/3 of cases, the cough does become productive. The third symptom is most worrisome, shortness of breath, suggesting fluid is beginning to fill the alveoli. This complaint is present in 15% of non-severe cases and observed in 37% of patients with severe disease. Fatigue and myalgias, or muscle aches, are other prominent symptoms. Headache is moderately frequent, while diarrhea, abdominal pain, and vomiting are less common. More recently, a significant number of patients have complained of loss of smell and taste, and if these symptoms are present, this strongly suggests the onset of COVID 19. To encourage pattern recognition, we train all of our medical students to create an illness script, which consists of four elements. First, epidemiology. In this case of COVID 19, as discussed earlier, we want to ask about travel to an endemic area such as China, Italy, or New York City, being exposed to a large crowd like a mega church, or going on a cruise. And finally, as in our case, exposure to someone with COVID 19 or exposed to someone with symptoms suggestive of this disease. Next, what is the pace of illness? Acute, developing over 12 to 48 hours, subacute, over 3 to 10 days, or chronic, developing over weeks to months. In the case of COVID 19, the onset is acute to subacute. Next, what are the classic symptoms and signs in this disease? It is fever, dry cough, and the most worrisome sign, shortness of breath. Finally, we should include past medical history because patients with this infection do worse if they have diabetes, hypertension, cardiovascular disease, chronic lung disease, or cancer. To summarize the symptoms and other key patient information required for evaluating COVID 19 patients, first, review epidemiology. Travel to an endemic area, exposure to a large crowd, or exposure to someone who's infected. Second, assess the onset of illness. In this disease, it should be acute or subacute. Third, identify the key symptoms. In COVID 19, they are fever, dry cough, and shortness of breath, fatigue, and muscle aches or myalgias. Less common symptoms include abdominal pain and diarrhea, and loss of smell and taste. And finally, remember to view the past medical history with regards to hypertension, diabetes, cardiovascular disease, chronic lung disease, and cancer.